he wants to present one case on fever. I request Dr. Jakini Srinivas, who is the head of the Department of Critical Care, Amor Hospital, Hyderabad, going to talk on discuss on fever case.
And medical
Good
director.
morning, all. Thank you,
Medical
David.
director also.
Sir,
Thank
good
you,
morning,
David.
sir.
Good morning, sir.
Ah,
Good morning, all. So, before going into the case, I'll just have a 5 minutes of 10 minutes of discussion of case who presented to us just 3 days before. A 28-year-old female from Eluru. She had a history of fever a month back, 1 month back. And then she high grade fever, chills and rigors. Then they evaluated for malaria, dengue, viral, which was negative. She took augmentin course for around 1 week. Fever subsided. After 10 days, she had loose motions, fever, and again loose motions. Then for 2 days. Then after 2 days, the has decreased. Motions has decreased, but fever is around 100. The grade has come down, and after 2 days, the patient became normal. Again, she got a fever after a week. Fever for 3 days. She again took antibiotics, prescription. Then she became better, and so after 3 episodes of first 2 episodes was in Eluru. Third episode was in they have gone to some idea clinics here somewhere. So they have done some investigation. So every time they have done investigations. Then last 5 days, she's complained of shortness of breath, and she stays here only nearby our hospital. Shortness of breath, fever. Then she dropped into our hospital emergency. Then I just saw that patient morning, looked into this. Then immediately I have done an she's having severe breathlessness, so I put on NIV in emergency and brought to ICU, and then we have done an ultrasound. So ultrasound showed bilateral pleural effusion, mild pericardial effusion. She's tachycardic, almost around 150. Then gave fluid boluses, temperature control, and started on antibiotics. This time, patient was taken augmentin, azithromycin, ciprofloxacin, all types of antibiotics she has taken in the last three times in a month. So this time I started directly on a meropenem on this patient, and teicoplanin I started. And she is having a mild rash over the body and a macropapular rash. So fever, rash, and then Amma, ఇది కాదు, sir. This is not the thing, sir. This is another case. So fever, rash. Then I have gone through all the reports of last 3 times. So they found that the CBP is normal. The platelets are around 1.3 or something, little bit low. Other than that, CBP is normal. Initially was WBC elevated, and later 2 times it is normal. And LFT SGOT PT is mildly elevated. Okay, it is 2 times. And AG reversal is there. Albumin is around 3, and globulin is around 5.5. And the CRP is elevated, and RFT, all the other things are normal. So how will we proceed, sir, in this patient?
Can I speak,
Sir.
David?
Please.
Sir.
First investigation.
So CNS wise, patient conscious, comfortable, following commands. NIV is required, oxygenation is maintained. CT also we have done. There is no
Sir.
consolidation or anything. Just bilateral pleural effusion is there, right more than left. Pericardial effusion. And we immediately thought it is a chronic fever. So we have done a contrast CT abdomen also. So because if you don't have an immediate diagnosis, patient is going to collapse because acute GI symptoms were there. The second episode. So contrast abdomen also is normal. So tachycardia, so broad spectrum antibiotics, and then we have put on ivabradine because heart rate is high. Then blood cultures, urine culture, CBP, RFP, LFT, CRP, procalcitonin, and అది ఇంకా ఏం పంపించవచ్చు మీ పేషెంట్
సార్ గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్ సార్.
Positive findings, pyrexia of unknown origin, more than a month of fever on and off, with pericardial effusion and pleural effusion, reversal of AG ratio, despite reasonably normal liver and kidney functions. So infection causes కన్నా నాన్ ఇన్ఫెక్టెడ్ కాజెస్ మీద ఎవాల్యుయేషన్ మోర్ కాన్సన్ట్రేటెడ్ గా ఉంటే బాగుంటుంది. ఆటోఇమ్యూన్ సైడ్ మా క్రానిక్ మ్యాలిగ్నెన్సీస్ లేకపోతే క్రానిక్ మల్టీ సిస్టమ్ డిజార్డర్స్ లైక్ సార్కాయిడోసిస్లు అంటే వీ హావ్ టు లుక్ ఫర్ ద నాట్ ఎ రొటీన్ థింగ్. అంటే నార్మల్ గా మలేరియావో లేకపోతే న్యూమోనియా, డెంగ్యూ ఫీవరు, లెప్టోస్పైరస్ ఇవన్నీ దాటిపోయి ఉంటాం మనం బై దిస్ టైమ్. సో వీ నీడ్ టు లుక్ ఇన్ టు సమ్ క్రానిక్ ఆటోఇమ్యూన్ డిసీజ్, రేర్ ప్రెజెంటేషన్స్ ఆర్ సంథింగ్ లైక్ ఎనీ మ్యాలిగ్నెన్సీ ఆర్ సెకండరీ అలాంటి క్రానిక్ ఇల్నెస్ రిలేటెడ్ ఫీవర్ గురించి వెళ్తే బెటర్ ఏమో చూసుకోవాలి ఇందులో. ద పాజిటివ్ ఫైండింగ్స్ నేను ఎందుకు ఆలోచిస్తున్నానంటే ప్లోరల్ ఎఫ్యూజన్, పెరికార్డియల్ ఎఫ్యూజన్, నాన్ రిజాల్వింగ్ ఫీవర్ విత్ ఏజీ రేషియో రివర్సల్, సంథింగ్ ఎక్కడో క్రానిక్ గ్రాన్యులోమాటస్ డిసీజెస్ వైపు వెళ్ళాలి, మ్యాలిగ్నెన్సీస్ కానీ. సో పెట్ స్కాన్ చేయిస్తారు, ఏఎన్ఏ ప్రొఫైల్ అవి చూసుకోవాలి. ఏమైనా థర్డ్ స్పేసెస్ నుంచి ఫ్లూయిడ్ తీసి కల్చర్స్ పంపించడం, అదే ప్లోరల్ ఎఫ్యూజన్ ట్యాప్ చేయడం, పెరికార్డియల్ ఎఫ్యూజన్ ట్యాప్ చేసి దాని రిలేటెడ్ డయాగ్నోస్లు ఇట్లాగా ఆలోచిస్తాను నేనైతే.
Sir. So I examined completely her. Then the lymph nodes అయితే ఏం లేవు సార్ ఆమె. ఈవెన్ మనం సిటీ చెస్ట్ చేసినాం, అబ్డామిన్ చేసినాం కదా, అండ్ ఆల్సో examined there is no lymphadenopathy. Then what as you mentioned in the back of our mind is something non-infectious cause is there. Because high grade fever తగ్గుతుంది వస్తుంది, and we can take it as a pyrexia of unknown origin because it is recently evaluated 4 times by doctors. And so మళ్ళీ బట్ ఇన్ఫెక్షన్ ప్యానల్ అయితే ఎట్లా పంపించారు కదా, ఫీవర్ ప్రొఫైల్ అంతా పంపించాము. అండ్ దిస్ టైమ్ అరౌండ్ విత్ మలేరియా, డెంగ్యూ, వైరల్, దీంతో పాటు స్క్రబ్, లెప్టోస్పైరోసిస్ కూడా ఎవాల్యుయేట్ చేసి పంపించాము. అండ్ we also have sent for the CRP is almost around 70 and procalcitonin also around 8. So because of the inflammation, because high fever is high grade 1 or 2 ఉంటుంది కాబట్టి tachycardia ఉంటుంది. So fever వల్ల the CRP and this one is also elevated, procalcitonin. Then we have sent AG reversal is there, so we sent for serum immunoelectrophoresis. Ferritin we have sent. And we are also thought of ANA profile as you mentioned, complements, okay, vasculitis ki Cianca, Pianca, Pampichamu. And so everything has negative except ANA. ANA is positive and it is confirmed as a SLE. And started on steroids. Absolutely in next 24 hours. She's off NIV, and next 48 hours she's off this one oxygen. pleural effusion and everything. She distress and her tachycardia, everything has come down. And she yesterday only we discharged her and with a follow up with her nephrologist. So easy. And just this is just a thinking that not to go only on infectious cases. Yeah.
So SLE, eh?
ISL, sir. This patient just married 2 months back. She's suffering with almost 1 month plus fever. They finally, this is one of the she's one of the doctor's relative known to me. So later they found diagnosis వచ్చిన తర్వాత then they called me. మీ దగ్గర ఉన్నారా సార్? చెప్పండి సార్. Let's go into the case. Sir, next slide, sir.
Yeah. Yes.
Sir, any inputs, Satish sir, for the previous case?
No, sir. As expected, I thought it is autoimmune untad anukunnanu.
Yes, sir.
Yes, sir. Thank you.
Yes, sir. Thank you. Sir, this is a 30-year-old male software engineer presented to emergency room with similar complaints: a high-grade fever, generalized weakness, swelling of the feet with skin rash, 3 days for facial puffiness, hoarseness of voice, and no other things like headache, laser neck rigidity, altered sensorium gani, chest tightness gani, em ledu. So again, patient was evaluated for malaria, dengue, serology outside. This time we also have evaluated. Next slide, sir. We also have evaluated for a fever profile. Then this is a rash, maculopapular rash over the extremities. Next slide, sir. Yeah, facial puffiness is seen. Subconjunctival hemorrhages are seen. Next slide, sir. Rash over the face. So he is tachypneic, tachycardic, temperature 1 or 2, is hemodynamic fair, and no lymphadenopathy, no icterus, pallor, cyanosis. And as we have seen, rash on the perioral and legs, hands, and back of the thorax. Subconjunctival bleeding, facial swelling is present. Next slide. And taking history, since again he had a history of 1 month back, history of fever. Fever one day, then they went to a doctor. They put a medicine. They gave antibiotics and all these things. And next 2 to 3 days, the fever subsided. And at that time, he also developed a mild rash after third or fourth day. Then they went to doctor. They said that they went to another doctor. They said that this is because of the antibiotics, the rash. So after total 5 days of treatment, he stopped antibiotics. Patient was fine. So as mentioned, the other systems were normal. So in view of febrile illness, 1 month, he had a fever. But now in this patient, we cannot think of a chronic fever because history of 1 month back fever, and now he has a fever with rash. He did not have any similar reports. If you see now the fever trend in most of the patients, most of them has continuously are having a fever and especially respiratory tract infections almost in a month 2 times. One patient comes to me with last 4 months. Every month he is having some respiratory tract infection and fever. So I told him that we'll evaluate for the chronic fevers, but he's exposed to multiple times exposed to the people, and then he's having a fever. So some of the tests I have done, but it doesn't look like a chronic fever. Repeated infection is the most possibility. So this patient had a history of fever once, and then now he is presenting. So the investigations were done, and the sulfarizone sulbactam was started. Chest X-ray was down. Next slide, sir. So he is having WBC elevated, neutrophilia, platelets are 1.35, creatinine 1.12, and SGOT is mildly elevated, fairly normal. creatinine and platelets. Only WBC is elevated and SGOT is mildly elevated. ABG is showing metabolic acidosis with the lactate elevated. So as usual, we give patient on fluid resuscitation and broad spectrum antibiotic. NIV was started. So we are looking into the now DD with high grade fever with its skin lesions. Next slide, sir. So it can be infectious, as Satish sir mentioned. It can be inflammation. Usually, you cannot at this point of time. I don't think I suspect malignancy in this patient. Now, I need little more information. And sir, even yes, sir, Amiru, Satish sir. Anyone?
No. No, sir, no. I'll go with the secondary level investigations కి వెళ్తాం అంతే. నాట్ ఆఫ్ ప్రైమరీ రొటీన్ ఫీవర్ కాదు అనుకుంటాం అంతే ఈ టైంలో.
డే సెకండ్ కదా ఇది.
Day 2, yes, sir.
ఆల్రెడీ ఆన్ అండ్ ఆఫ్ ఫీవర్ అన్నారు
Hey,
కదా.
history was there, no, since 1 month.
1 month
Normal
back
antibiotics usage.
నార్మల్ గా ఫీవర్ ప్యానల్ లో ఈ 6 చేస్తాం కదా, స్క్రప్టైబస్ అండ్ లెప్టోస్పైరా, మలేరియా, డెంగ్యూ, కోవిడ్,
yes, sir.
బట్ ఇవన్నీ 6 చేస్తాం కదా.
అవును సార్. అంటే
ఆ తర్వాత
ఫీవర్ విత్ మల్టీ ఆర్గన్ ఇన్వాల్వ్మెంట్ ఉంటే వీ షుడ్ థింక్ ఆఫ్ ఆల్ ద ట్రాపికల్ ఫీవర్స్ ఇన్ ద లిస్ట్. రూల్ అవుట్ మలేరియా, రూల్ అవుట్ లెప్టో, స్క్రబ్ అండ్ డెంగ్యూ. సో దానికి రిలేటెడ్, బట్ ఇట్ ఇస్ టూ ఎర్లీ ఫర్ దట్. ఇఫ్ ద ప్రీవియస్ ఫీవర్స్ ఆర్ ఇగ్నోర్డ్, 2 days fever, usually most of the test will be negative except NS1 dengue.
Yes, agree.
Any fever case, hemodynamically stable, maybe derangements of some organ dysfunction. But hemodynamically stable for long history of fever, I don't think patient will deteriorate rapidly, and they will give time for evaluation.
Yeah. So patient continued to remain febrile and rash worsened, and skin biopsy and tissue culture was sent. So then we evaluated skin biopsy. What they are saying inside is an inflammatory reaction. Other than that, it is not evident of any of the disease. So the its perioral lesions developed and increase in severity. Blood culture showed no growth on day 2. And PCT was 26.8, more looks like this one. And then we started asking patient wife. They are basically North Indians, but so we asked the patient wife, is he developing any fever? Because 1 month back he had a fever, just recollect it. Then with the history, they said that we went to some outstation 2 months back. He had 2 days or 3 days of fever, and we went to a doctor there. Then all were normal. He said normal. And this month, last month, we had a fever. And 15 days back also, he had a fever, but already we did not go to a doctor. But we took a prescription, what the doctor was prescribed 1 month back. We have repeated it. So both the test and tests were normal. Then we have repeated the same treatment. So it has subsided. So with a clear history, I could point out something chronic fever is going on in this patient. So we have sent for a chronic evaluation. We started ANA, for vascular C3, C4 levels, and CANCA, PANCA. And then echocardiography was normal. Platelets were down. Ultrasound abdomen is normal. And patient febrile is slightly altered sensorium in view of high grade fever. So platelets were down 66,000, planned for CSF analysis, but was postponed in view of thrombocytopenia. Ferritin was elevated 23,760, but it's an inflammatory marker, ferritin, which we can think, but such a high, we need to definitely we need to look into the caution. So ANA profile negative, Priyanka negative, anti-CCP was negative, and we have took a hematology consult. And we thought here itself it says that we can get a diagnosis on day 4. We had done a bone marrow to rule out lymphoproliferative disorder and infections, as no obvious connective tissue disorder is being found to be positive. So aspirate shows toxic granules and increased myelopoiesis blast less than 1%, and platelets fell to 29,000. We have done immature platelet factor, which shows that suppose a patient who is having low platelets, we can think of like a reticulocyte count in WBC. Reticulocyte count in for hemoglobin, low hemoglobin. We can also do a immature platelet factor for the platelets, whether the bone marrow is producing or not the platelets. So creatinine increased to 1.8. The IPF was normal, and so that means there is a lot of destruction happening, and antibiotics escalated to meropenem teicoplanin. LDH is 4,924, and fibrinogen is 219. Wound culture grows staph aureus MSSA. Are we happy here, or should we go ahead, sir? An investigation chedama. There is a bone marrow report, and MSSA has grown. Okay, so bone marrow normocellular, bone marrow showing trilineage hematopoiesis. That means almost like a normal. Next slide, sir. Okay, normocellular. Final impression is normocellular bone marrow showing trilineage hematopoiesis. Next slide, sir. Yeah, this is the immature platelet factor, which is 12.9. There's a production is good because low thrombosis. This one is low. Platelets are low, so we have sent for this, and then it is showing normal. That means production is good. Next slide, sir. Previous slide, sir. Previous slide, sir. Previous slide. Yes, sir. Sir, anything to discuss here, or you want to go ahead with any other diagnosis or anything? Patient is sick. He is on NIV. His organ failure is worsening, and we don't have any diagnosis at this point of time. Patient is on. So WBC elevated, fever present, patient on NIV, creatinine is elevated, and we MSSA in the wound. So are we happy, sir? Anyone?
Chronic infective disease like milioidosis.
Sir?
Chronic infective diseases like milioidosis, Pseudomonas, pseudomyele, long-term things to be evaluated, sir.
Sir?
Is there any significance of this MSSA related to this severe thrombocytopenia and elevated procalcitonin levels? I am suspecting this MSSA causing this.
Sorry, where is the MSSA?
In wound.
ఎక్కడ wound ఏంటి?
ఏ wound అన్నది?
సార్ ఈయనకి ఇది ఉంది కదా సార్, ఇది ఇక్కడికి ఈస్ హ్యావింగ్ దిస్ ప్యాచెస్ వస్తున్నాయి కదా,
స్కిన్
మ్యాక్యులోపాపులర్ ర్యాషెస్ ఇది బర్స్ట్ అవుతున్నాయి కదా,
స్కిన్ లీషన్స్.
High grade fever, altered sensorium, and rapid fall of platelet counts and severe inflammatory process is going on. Ferritin levels are 23,000, and LDH also is very high, more than 4,000. Have you done any TE, transesophageal echocardiography?
No, sir.
Possibility of bacterial endocarditis.
Endocarditis possibility also is there because procalcitonin is also high and MSSA is there. So that should be ruled out. And have you done any PET scan?
No, sir. Patient on NIV.
Patient on NIV?
NIV?
Oh, CT scan ఎలా ఉంది? CT chest.
Sir, CT scan చెస్ట్ చేసాం సార్, ఇది సిటీ స్కాన్ చెస్ట్ చేయలేదు పేషెంట్ కి. నార్మల్ అల్ట్రాసౌండ్ అబ్డామిన్ ఇస్ నార్మల్.
CT abdomen, CECT anything?
చేయలేదు సార్.
ఎందుకని అంటే డే 1 పేషెంట్ ఆన్ NIV, డే 1.
Day 1, no sir. Day 1 patient is on oxygen only.
Day 2?
Day 2 patient is on NIV.
So you are not doing any CT scan or anything patient on NIV?
Sir, we can do, but only patient is sick. So అందుకనే ట్రాన్స్పోర్ట్ చేయలేదు, బట్ ఎక్స్రే లుక్స్ నార్మల్.
This case needs all investigation కదా, CECT abdomen also. ఓకే, నెక్స్ట్ వెళ్దామా?
సార్ ఇది ఇంకేమైనా క్రైటీరియా ఉండొచ్చా సార్? ఇవి ఉండొచ్చా? HLH?
యా, డెఫినెట్. HLH ఇప్పుడు మైలోప్రొలిఫరేట్ చేశారు కదా టెస్ట్. వాట్ ఈస్ బోన్ మ్యారో ఇస్ నార్మల్ కదా.
బోన్ మ్యారో ఇస్ నార్మల్.
HLH కి వాట్ ఆర్ ద క్రైటీరియా టు కన్ఫర్మ్?
And lipid, high lipid profile and high serum creatine levels, and the main diagnostic criteria is you will see the phagocytes. What is that?
Sir, major criteria,
phagocyte
minor criteria ఉంటాయి. So normal గా ఏంటంటే most of the patients in sepsis or extended sepsis fits into HLS criteria. Significant thing is hemolytic anemia లాంటిది ఉంటుంది. Opinion ఉండాలి. Elevated serum ferritin is a clinching diagnosis to look for HLH. So HLS is not an independent diagnosis, it's a pathological diagnosis. It's an extension to the infection also.
It can cause with infection or non-infection. It can be anything.
Both the things.
Non-infectious also.
Both the things, but it's an extension. It is a pathological diagnosis. It's not a direct.
It is a high inflammatory response to any insult, either infectious or non-infectious. So we had one HLS case and that patient recovered well. So, but the diagnostic is the bone marrow shows. I forgot that one lymphoproliferative disorder. They will identify.
ఏంటో డేవిడ్ మీ దగ్గర అందరూ రికవర్ అయిపోతారు, మా దగ్గర ఎవరేంటి?
అలా ఏం లేదులేండి సార్.
సార్ ఇది మ్యాక్రోఫాగోసైటోసిస్ ఉంటది. వేర్ దిస్ మ్యాక్రోఫేజెస్ దే on a staining you will see that mostly ఈ పేషెంట్ కి either WBC ప్లేట్లెట్స్ తక్కువ ఉంటాయి యూజువల్ గా, బికాస్ ఈ మ్యాక్రోఫేజ్ అనేది అన్ని తినేస్తూ ఉంటది.
మ్యాక్రోఫేజెస్ లో హిస్టోసైట్స్ ఉంటాయి. దట్ ఈస్ ద డయాగ్నోస్టిక్.
సో
నార్మల్ కదా.
యా, సో ప్లేట్లెట్స్ తగ్గుతాయి, అందుకనే ఈవెన్ హిమోగ్లోబిన్ విల్ డిక్రీజ్ because phagocytic action on the bone marrow and also outside destruction idi, and WBC పెరగొచ్చు తగ్గొచ్చు. As Satish sir mentioned, it's a syndrome, nothing to do with the disease. Okay, so next sir ఇది ఇలా స్పెసిఫిక్ గా కొన్ని ఉంటాయి. ఏంటంటే హైపోఫైబ్రినోజెనీమియా ఉంటది. Here I have shown fibrinogen is normal in this patient. Fibrinogen ఉంది కదా అన్న ప్రీవియస్ స్లైడ్. ఇక్కడ 2 things. One is fibrinogen is normal ఇక్కడ, and also LDH high also reflected. Next slide sir. Yeah, and serum ferritin is very 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 high. So next slide sir. Yes, bone marrow shows normocellular trilineage hemoptysis, persistently febrile, and after ruling out all infectious, these are marrow suspected to have connective tissue disorder. So based on MIBG criteria, patient has found to have an adult onset Still's disease and probably in a macrophage activation syndrome and are initiated on steroids. So rheumatologist opinion was taken and steroids 1 gram was continued for 5 days and tapered to oral therapy. So gradually improved, fevers controlled and rash subsided, platelets improved to 1.5 lakhs at the time of discharge. A short antibiotic course was continued and stopped on day 7. Swelling over face, limbs, edema, ulcerations healed and kidney function improved with a stable creatinine proteinuria subsided. Next slide sir.
Here before you start this methylprednisolone pulse dose, already progesterone is very high in 27.
Sir,
What about that? Did you rule out the infection, possible infection in the blood?
sir, CT
Progesterone
అయితే
is high.
అప్పుడు సార్ ఒకటి ఏంటంటే, so as we all know that procalcitonin is an inflammatory marker and it rules out infection.
Because
So,
toxic granulation is also found in the bone marrow. Toxic granulations also are there.
toxic granules are there, but it is not high, sir. If it is more than 10%, then we can think of an infection, gram-negative infection.
Cultures are not growing, no? Anything?
MSSA వచ్చింది కదా సార్?
అదే MSSA ఉంది,
wound నుంచి.
progesterone high ఉంది,
wound
toxic
నుంచి.
granulations are there. మరి will it cause methylprednisolone?
wound నుంచి MSSA we can think of colonization.
Correct.
Blood and urine has not grown anything.
Did you think of this pulse dose will cause a severe immunosuppression and worsening of the sepsis?
Sir, the ferritin is extremely high. It's almost 27,000.
Positive things are there to start and some negative things are there. ఇక్కడ మనం did you think of any immunosuppression and worsening of the condition same time?
Sir, ikkada we are not obviously seeing any site of infection.
Sir,
Other than
can I talk?
yes, yes.
సార్ ఈ పేషెంట్ విషయంలో ఏఎన్ఏ ప్రొఫైల్ కూడా నెగిటివ్ వచ్చింది కదా?
అవును.
మరి ఇట్ ఈస్ a very daring step to start just looking at the ferritin and that is the only positive thing to start steroid because non-resolving. But other side is, as David said, MSSA is already there in the body, procalcitonin elevated. We cannot rule out an infection cause, but starting pulse dose steroid at this point of time is a very daring step.
Sir, if you look into all the criteria, these are all fitting into the Yamaguchi criteria. Just next slide, sir. Next slide.
ఆ ప్రోటోకాల్ ఏంటి? అది పెట్టిన ముందు స్లైడ్ ప్రోటోకాల్ ఏంటి?
ప్రీవియస్ సార్, ఇది దీంట్లోకి వెళ్ళి ఫ్రమ్ ద హారిసన్ నుంచి తీసింది. ఇది ఫీవర్ మోర్ దాన్ 38.3 or 101 and illness lasting more than 3 weeks, no known immunocompromised state ఉంటే history and physical examination, stop antibiotic treatment and glucocorticoids. Obligatory investigations, ESR, CRP, hemoglobin, platelets, WBC.
Here the criteria starting steroids is 3 weeks. Here the criteria starting steroids is 3 weeks.
అర్థం కాదు సార్. ఫీవర్ ఫర్
No, you said
you need we need to wait for 3 weeks to start steroids, sir.
Yes.
Why 3 weeks? If patient is rapidly deteriorating, can you wait for 3 weeks? No, if HLH severe.
No, non-infection causes 3 weeks ఆగమంటున్నాడు. I don't know. That's what I want to ask what it is because I'm not able to see the literature clearly. I just got the point.
Even non-infectious causes, patient will deteriorate rapidly, no?
But I don't know. That's what that paper. That's what he's talking. I don't know. Please.
Yes, sir. Okay,
sir, ఈ పేషెంట్ కి there is a history ఉంది ఫీవర్స్.
ప్రీవియస్ ఉందిలే, అది కాదు.
రిపీటెడ్ హిస్టరీ ఉంది. ఇప్పుడు వర్సన్ అవుతున్నాడు వాడు.
ఇప్పుడు you cannot wait another 3 weeks to rule out కదా.
So protein electrophoresis, alk phosphate, AST, ALT, LDH, creatine kinase, ANA, RA factor, ఇవన్నీ కూడా చేసాం. యాక్చువల్గా RA factor is negative, ANA is negative, and protein electrophoresis is done, which is normal, and blood culture, urine culture, chest X-ray, abdominal ultrasound, and tuberculin skin test. Tuberculin చేయలేదు. Exclude manipulation.
బోన్ మ్యారో వీడు చెప్పలేదు.
వీడు బోన్ మ్యారో చెప్పలేదు సార్. సో previously, suppose if you got a guided diagnosis, no diagnosis, then You can go for cryoglobulin and fundoscopy. And చెప్పాడు కదా every PET scan చెప్పాడు. And repeat history and physical examination, it means CT chest and abdomen, temporal artery biopsy.
PDC present, PDC absent. PDC అంటనా?
ఇది
What is PDC?
No, this is predicting of diagnosis, clinical diagnosis. And if you are able to predict as per the symptoms and this one able to predict a diagnosis. Clinical diagnosis basically.
Absent to present అంటేనా?
అదే అంటే ఇప్పుడు సపోజ్ ఇఫ్ యూ టేక్ ఎ ర్యాష్, ఫీవర్ ఉందనుకోండి, యూ కెన్ ఆల్సో థింక్ ఆఫ్ ఎ ఫీవర్ విత్ ర్యాష్, ఇన్ఫెక్షన్స్ కాకుండా యూ కెన్ ఆల్సో థింక్ ఆఫ్ ఎస్ఎల్ఈ, తర్వాత ఇంకా మన ఇది ఫెంఫిగల్స్, ఇట్లాంటివన్నీ అనుకోవచ్చు కదా.
ఓకే,
అది నెక్స్ట్ స్లైడ్. Next slide. Next slide, sir. Next slide. Yeah. So it is another rare autoimmune inflammatory disease, and 1.5 cases per 1 lakh, predominantly females compared to males. Next slide. So looked into the diagnosis of made a Yamaguchi criteria. So this is only basically a diagnosis of exclusion. Only after potential differential diagnoses were ruled out. So classic triad is, I think, fever, arthralgia, Sanman color, patches. So next slide, sir. Yeah, because of the inflammatory, you all know that because of the inflammation, it causes all this. Next slide, sir. So as we discussed already, macrophage activating syndrome, we discussed many times. So next slide, sir. So the laboratory test usually will be ESR will be elevated, leukocytosis, and thrombocytopenia and elevated ferritin levels are seen. Next. Ferritins are often more than 2000 than the level found in other autoimmune or inflammatory disease and are likely secondary to cytokine secretion induced by reticular. So specific characteristic features are in this. Usually around ferritins around 2000 to 3000 at long time elevated. But in this patient, it is almost like 25,000. So this is a characteristic feature, and usually 10,000 can some literature says that it is more looks like a adult onset Still's disease. And we have to see, and studies have shown that a combination of glycosylated ferritin fraction less than 20% and ferritin level above the upper limit of the normal range improves the sensitivity and specificity as compared with only with the ferritin levels. Next slide. So in this, the major criteria are fever of at least 39 degrees for at least a week, arthralgia or arthritis for at least 2 weeks, non-pruritic salmon colored rash on trunk extremities, and granulocyte leukocytosis more than 10,000. Minor criteria are sore throat, lymphadenopathy, hepatosplenomegaly, abnormal liver function test, negative test for RF and ANA. So diagnosis requires at least 5 features, with at least 2 of these being major diagnostic criteria. Our patient had all 4 of the major criteria: fever undi, arthralgia, rash undi, WBC is elevated, and all of the minor except lymphadenopathy. Lymphadenopathy tappa he is having sore throat, hepatosplenomegaly, abnormal liver function test, negative for rheumatoid factors and ANA. Next slide. So this is one of the new criteria to marker serum ferritin and glycosylated ferritin, and was added into this, and 3 major and 2 minor criteria: fever, arthralgia, erythema, pharyngitis, inflated WBC, and glycosylated ferritin less than 20%. and minor are typical Still's rash and leukocytosis. Next slide. It is basically a diagnostic of exclusion. We need to rule out all infections like rubella, Epstein-Barr virus, CMV, HIV, HPV, hepatitis C, B, and infective endocarditis, TB, Lyme disease. And we have to rule out Crohn's disease, sarcoidosis, idiopathic granulomatous hepatitis, leukemias, lymphomas, connective tissue disorders, PAN, Wegener's, and Taggart's arthritis. Next slide. Disease is divided into three types. One is monocyclic, polycyclic, or chronic articular pattern. The single episode, monocyclic, is followed by complete remission. Intermittent, where 2 or more episodes with a symptom-free period lasting for a minimum of 2 months. And chronic articular pattern, which is characterized by the severe articular manifestation. Treatment is with steroids, and they later will be on disease-modifying anti-rheumatic drugs, whether Trixide, azathioprine, cyclosporine, cyclophosphamide. And in the severe cases, plasma exchange and IV immunoglobulins are other treatments in refractory conditions. Next slide. For the past 4 decades, ASD still remains a diagnostic dilemma for physicians as it presents with a combination of non-specific symptoms, wide variety of diseases, present with prolonged and unexplained fever combined with musculoskeletal symptoms and rash. The differential diagnosis should include AOC. Timely diagnosis and treatment of disease can prevent complications, lead to favorable prognosis with improved quality of life. Thank you, sir. Thank you all. Any comments, questions?
Thanks, Anna. Very rare and very nice presentation. Both the cases you identified
In diagnosis, any Still's, sir?
Still's disease. So, you diagnosed properly and treated rare cases, SLE and AOSD. Recently, I put one ABG in our group. Only one person responded, Dr. Shyam, that he said because it is methemoglobin is high, so he said methemoglobinemia. But next I put history of fever and severe anemia. So that is the cause, and treated for fever. Patient presented with saturation of 70, but no breathlessness. ABG methemoglobin is around 15, and but SaOT is 98, SpOT is 70. His hemoglobin is 3. So at the time of having fever in Orissa, the patient hemoglobin is 10, but he dropped to 3, and his LFT is elevated because hemolysis. So then after that, nobody is responded. Can you explain that? What could be the reason? And he treated for malaria.
From the place he has come from, Orissa, malaria treatment, G6PD deficiency ఏదైనా ఉందేమో చూసుకోండి.
Yeah, he used Primaquine.
Yes.
So what they did, they are giving blood transfusions. But hemolysis is there, and the hemolytic jaundice is there. Hemoglobin is rapidly come down, and the hematologist has written all the anemia pack workup except G6PD. So that patient is shifted for ICU for only blood transfusion. So then myself and Varalakshmi are seeing that patient. Just think of G6PD only, but they are not written for G6PD. They have written all these panels and nocturnal hemoglobinopathies, everything. But patient attendants, they don't have money, so said they're not willing for doing any investigation. So we thought of same G6PD. Started Primaquine. It is one of the drug to cause severe hemolysis when patient in G6PD deficiency. Actually, it is advised before you start to rule out G6PD.
It is advised గానీ but
But
we don't do
nobody will do. Yeah, correct.
it.
But rarely we'll see, no, we will never see. The first time I have seen of starting Primaquine, after 1 week patient having this type
Sir,
of
ఇది we use only for the Vivax కదా సార్ ఇది.
Vivax వాడతాం.
Hmm.
Because Valciparam they don't have secondary cycle.
అదే అంటే Vivax వాడతాము బట్ ఓకే బట్ ఈజ్ ఇట్ పాజిటివ్?
Yeah, there it is positive malaria, Vivax. So they have
ఓకే
Valsico they have started followed by Primaquine to
ఓకే
prevent
ఫైన్.
recurrence. Yeah.
Hmm.
So after 1 week, patient presented with breathlessness, not breathlessness actually, severe weakness and fatigue. So we have this 3 grams HB and all these things. And ABG shows I put in the Morton group also. G6PD not done.
No,
But,
ABG shows what in G6PD deficiency?
Sir, methemoglobinemia, severe patient having severe methemoglobinemia and saturation was 70%. ABG lo. HB is 3 grams. It fall within 2 days, fall from 10 to 3. Is there any role of stop the drug or anything you need to start for this patient? Steroid or anything? Yeah, no?
సార్
Patient ki a drug stop cheyadamena blood ivatam or anything you need to start? Any steroid or anything? ఏం అవసరం లేదా? హలో హలో వారు మాట్లాడలేదేంటి?
సార్ గుడ్ మార్నింగ్ సార్. మీరు ఎలా ట్రీట్ చేశారు సార్?
ఇప్పుడు ఏం జరిగిందంటే వాళ్ళు దే డోంట్ హ్యావ్ మనీ, సో దే డోంట్ వాంట్ ఎనీ ఇన్వెస్టిగేషన్. ఇవన్నీ కాస్ట్లీ కదా. ప్యానల్స్ చాలా రాశాడు హెమటాలజిస్ట్, బట్ ఎక్సెప్ట్ G6PD అతనికి ఐడియా రాలేదేమో. మేము అడ్వైజ్ చేసాం. పేషెంట్ వార్డ్ పేషెంట్, జస్ట్ బ్లడ్ ట్రాన్స్ఫ్యూజన్కి వచ్చాడు ఐసీకి. కెన్ వీ థింక్ ఆఫ్ దిస్ థింగ్? ఆ ఏబీజీ అది చూసి నేను ఫోటో తీసి గ్రూప్ లో పెట్టాను. నో హిస్టరీ ఆఫ్ పాయిజనింగ్.
ఏమైనా ఉందా సార్? మరి ట్రీట్మెంట్ ఏమైనా ఉందా?
ఏం లేదు ట్రీట్మెంట్. ఆడు ఫీవర్ అన్ని తగ్గిపోయినాయి, ఓన్లీ బ్లడ్ ఇస్తున్నారు అంతే.
స్టాప్ చేసేసిన అంతే కదా?
అది స్టాప్ చేశారు. అంటే
అంటే స్టాప్ చేసిన తర్వాత ఎన్ని రోజులకు రెస్పాండ్ అవుతాడు
తెలీదు అన్న. అందుకే జస్ట్ ఒకరోజు చూసాం మేము మళ్ళీ వాటి. బికాజ్ రేర్ కేస్ వీ వాంట్ టు ఫాలో దట్ కేస్. ఇంకా చూడలేదు, చెక్ చేయలేదు. ఇంకేంటి
లెవెల్స్ చేశారా? G6PD
చేయలేదు. వాళ్ళు మనీ లేదు, పూర్. వాళ్ళు ఇన్వెస్టిగేషన్ ఏమొద్దు, బ్లడ్ ఎక్కించుకొని వెళ్ళిపోతాం.
అప్పటికే ఇవన్నీ చేసేసి ఉంటారు కదా మిగిలిన టెస్ట్లు.
చేయలేదు, ఏది వాళ్ళు ఒప్పుకోలేదు. అది
ఓకే ఓకే.
ఓన్లీ ఎల్ఎఫ్టి చేశారు. ఎల్ఎఫ్టి ఇస్ ఎలివేటెడ్. హిమోలైటిక్ జాండిస్ ఇస్ కన్ఫర్మ్.
ఎంత
LDH is high.
డెఫిషియన్సీ డేవిడ్?
అదే సార్ చేయలేదు, వాళ్ళు మనీ లేదని వాళ్ళు
కాస్ట్ ఎంత అవుద్దని అడుగుతున్నాను.
మరి తెలియదు సార్. మరి
మీ దగ్గర చేస్తారా?
లేదు, బయటికే పంపాలి.
సార్ పేషెంట్ ఉన్నారా? డిశ్చార్జ్ అయిపోయారు?
ఉన్నాడు వార్డులో ఉన్నాడు.
అంటే ఒక శాంపుల్ తీసుకొని అంటే తక్కువైతే మనం విజయాల మాట్లాడొచ్చు కదా.
అందుకోసమే అనరాదా?
అదే కనుక్కొని ఒకసారి మనం చేస్తే అట్లీస్ట్ అకాడమిక్ పర్పస్ విల్ నో వాట్ రేర్
అంటే
కేస్.
ఒకవేళ పాజిటివ్ అంటే మీరు పేపర్ రాయడానికైనా బాగుంటుంది కదా.
చేద్దాం. ఐ విల్ సెండ్ టుడే. ఎస్టర్డే ఓన్లీ ఐ సా దట్ థింక్ ఆఫ్ సెండింగ్. టుడే ఐ విల్ సెండ్ దట్ శాంపుల్. ఇంకా దానికి రిలేటెడ్ గా ఏం చేయాలో చూసి లిటరేచర్ ఐ విల్ సెండ్.
సార్ HB3 కదా, సో ఓన్లీ ఫ్లూయిడ్ ఆర్ ఓరలా లేకపోతే బ్లడ్ కూడా ట్రాన్స్ఫ్యూషన్ చేయొచ్చా?
బ్లడ్ ట్రాన్స్ఫ్యూజన్ ఇస్తున్నాం.
అంటే హీమోలైటిక్ లోని బ్లడ్ ట్రాన్స్ఫ్యూషన్ ఏమైనా ఇష్యూ ఉంటుందా స్పెసిఫిక్ గా ఈ
అంటే
పేషెంట్ కి?
ఆన్ గోయింగ్ హీమోలైసిస్ అయితే నువ్వు ఇస్తా ఉంటే అది లైజ్ అవుతానే ఉంటుంది. బట్ వన్స్ యూ స్టాప్ ద డ్రగ్ విచ్ ఈస్ కాజింగ్ హీమోలైసిస్, then because patient is HB is very low, so you need to transfuse to stop the causing agent which is causing the hemolysis. It is actually from 3 to it is improved to 7 after 3 units of blood. So we stopped after 3 units, but I will follow this case because patient the word.
So you are given packed RBC or whole
PRBC
blood or
only. No, only PRBC. Nothing.
PRBC. Okay.
Coombs test, all these things done. Coombs negative, direct and indirect, and LDH is high because of hemolysis. Only thing is G6PD should be done. You need to rule out. No, nice presentation. Very good cases. We discussed all these 2 cases we explained.
Thank you,
Is there
sir.
any no further questions? We will close the session.
Thank
కాదు,
you.
పొద్దున్నే మోహన్ రావు సార్కి
Ah.
డౌట్ వచ్చింది. సార్ మీకు స్లైడ్స్ ఉన్నాయా లేకపోతే ఊరికే నోట్ తో క్వశ్చన్లు అడుగుతారా అని.
నేను ఏదైనా చేయగలను అన్నారా?
స్లైడ్స్ ఉన్నాయి సార్ అని
నా
చెప్తున్నాను.
ఇష్టం. డేవిడ్దే తప్పు ముందు రోజు చెప్పాడు, నా తప్పే లేదన్నారా?
సరే, ఓకే ఓకే సార్.
Okay, Anna. Thank you.
Okay, sir. Thank you.
Thank you for the presentation, and thank you all the audience for the active participation.
Thank you, sir. Thank you to all.
అవసరం.